Hello, and welcome to Medtronic Global Grand Rounds. My name is Cindy Walker, and I'm the Vice President of Global Medical Education for Medtronic CRT-D. On behalf of Medtronic and our incredible faculty, I would like to welcome you to today's Global Grand Rounds event. These web-based programs are interactive and available to you on your laptop, smartphone, and tablet. We intend to bring you the industry's finest faculty from around the world to discuss pertinent topics in the field of electrophysiology. Following today's event, you will be able to view the proceedings on the Medtronic Connect website. On behalf of Medtronic and our incredible faculty, thank you for joining us today.
Today we have an important topic for CRT, the BLOCK-HF trial. BLOCK-HF was a rigorous, randomized, double-blind controlled trial of RV versus biventricular pacing in patients with AV block and systolic dysfunction. In the trial, we found out that biventricular pacing provided better results and better outcomes for the patients than RV pacing. Today I have with me Professor Dr. Ann Curtis, who is the PI of the trial. More than 12 years ago, I invited Ann to be the PI of this trial. She is currently the Charles and Mary Bauer Professor and Chair, Department of Medicine at the University of Buffalo in Buffalo, New York. She has held numerous national leadership positions, from the President of the Heart Rhythm Society to the Chair of the Cardiovascular Devices Advisory Panel for FDA.
It's my pleasure today to talk to all of you and go over the results from the BLOCK-HF trial, which actually provide us with new indications for CRTD and CRTP in certain patients that we'll go through. So first of all, just to set the stage, the problem that we're talking about is AV block. There are over 5 million Americans who are indicated for pacing therapy, and over 1 million of them have AV block. And so we know that there are indications for pacing in these patients, and the real intention of BLOCK-HF was to look at what is the best way to treat those patients. Why did we ever bring that up in the first place? Well, first of all, we've had some information from clinical trials that have indicated that patients don't necessarily do very well when we pace the right ventricle all the time, even though dual chamber pacing restores systole in such patients. So one of the studies that has given us this information is the DAVID trial, which looked at DDDR versus VVI pacing in patients who had indications for ICD therapy. Now, the way the trial was designed, there was actually a very, very low percentage of ventricular pacing in the VVI group, whereas the group that had dual chamber pacing had a much higher percentage of right ventricular pacing, on upwards of around 70% or so. The interesting finding from the study was that when patients who didn't already have an indication for pacing had a lot of right ventricular pacing, their outcomes were worse. And in this trial, it was death or first hospitalization for heart failure. They did worse with the RV pacing in the dual chamber mode than when a simple backup VVI pacing was used. In the MOST trial, when it was looked at with, and again, this is patients who had dual chamber pacing, didn't necessarily have AV block, but if you looked at the percentage of pacing in these patients, and this was all RV pacing, this is not CRT therapy, but when you look at the percentage of pacing, once patients got over 40% of the time with ventricular pacing, their outcomes were worse compared to patients who had less pacing. And it was a 3 times increased risk of congestive heart failure hospitalization. So these are just a couple of examples of studies that show that excessive amounts of RV pacing in patients can lead to worse outcomes. So now the BLOCK-HF trial was designed to look at patients with AV block. If you have AV block, you must pace the ventricle. And in such cases, the question we wanted to look at was whether if you pace these patients with CRT therapy compared to RV therapy, whether or not outcomes would be better. So the objective of the study was to see whether or not CRT was superior to right ventricular pacing in patients with AV block and left ventricular dysfunction. We had a composite primary endpoint of all-cause mortality, heart failure-related urgent care that was required intravenous therapy. So it might have been a patient who visited the emergency department who got hospitalized for heart failure. And then finally, the third component of the composite endpoint was a 15% or more increase in left ventricular and systolic volume index. So once a patient met any one of these three components of the primary endpoint, they were considered to have met the primary endpoint. Inclusion criteria for the trial included, first of all, a class 1 or 2A pacing indication, but then beyond that, the patient also had to have AV block. So specifically, second or third degree AV block. They could have had first degree AV block with symptoms similar to pacemaker syndrome and an excessively prolonged PR interval, or documented Wenckebach or a PR interval over 300 if they were paced at 100 beats per minute in the atrium. In addition, they had to have a left ventricular ejection fraction of 50% or less, and New York Heart Association class 1, 2, or 3 symptoms. Exclusion criteria included an already existing indication for CRT therapy. So this was not revisiting previous trials of CRT therapy, but looking at a new population that had not previously been indicated for CRT. In addition, patients were excluded if they had valvular heart disease and were indicated for a valve or might be indicated for valve replacement or repair, and then if they had unstable angina or a recent intervention, either percutaneous coronary intervention or bypass surgery, they would have been excluded, as were patients who had a recent MI. So here's the design of Block-HF. So first, a patient would have been implanted with a CRT device, and it would have either been a CRTP or a CRTD, and CRTD devices would have been implanted if the patient independently met an indication for defibrillator therapy. After the device was implanted, the patients had optimal medical therapy established. We know that there are medications that should be used in patients who have heart failure, but if you have a patient who has second or third degree AV block, it's not possible to put them on indicated beta blocker therapy until they have the protection of a pacing device in place. So that was the rationale for the way the trial was designed, to implant first, optimize medical therapy, and during that period of time, all of the patients in the trial were RV paced. And then at 30 to 60 days after medications were optimized, the patients were randomized 1-to-1 to either biventricular pacing or RV pacing. And then they were followed up every 3 months after that with echocardiograms every 6 months. Here's the study flow diagram. So after enrollment, we had 918 patients who were assessed for eligibility. Now 160 patients were not implanted, and the reason for that were several. The most important one was that patients did not meet inclusion-exclusion criteria. Well, how could that be when you enroll the patient? The most common reason, actually, was that when patients were paced in the atrium at 100 beats per minute, they were able to conduct 1-to-1 to the ventricle. And in such cases, it was considered that those patients could have minimized ventricular pacing by some of the existing algorithms, and therefore that would be the way to treat those patients rather than forcing pacing in the ventricle by cardiac resynchronization therapy. So those patients were excluded. There were some other patients who either had unsuccessful implants or who withdrew consent prior to implantation. So ultimately we had 691 patients who were randomized 1-to-1 either to biventricular or RV pacing. Most of the patients received the allocated intervention, and then they were followed after that. These are the baseline demographics from the study, and what you can see are that the treatment groups were well balanced. On the left-hand side are shown the CRTP patients, and on the right-hand side the CRTD, and you can see that about 2/3 of the patients actually were in the CRTP arm. Most of the patients were male. The average age was in the 70s. The group with CRTP was slightly older. The mean ejection fraction that's one thing I want to point out here, in that the CRTD patients had a lower mean ejection fraction, not surprisingly, at an average of about 33%, compared to the CRTP patients whose mean ejection fraction was 43%. Now the reason there is that patients with lower ejection fractions are more likely to meet indications for primary prevention defibrillator therapy and therefore would have been implanted with a CRTD device. The number of patients who had LV ejection fractions over 35%, again, very commonly in the CRTP group, was much higher, 87 to 89%, much lower in the CRTD group. Most of the patients were New York Heart Association class 2 or 3. Most of the patients had second or third degree AV block, and there was left bundle branch block present in about a third of the patients. What this slide shows you is that there was a high median percentage of RV pacing. It was 98.5% prior to randomization. So what this is showing is that these patients did have a high percentage of pacing. They needed pacing. As I mentioned, many of the patients had second and third degree AV block, and you cannot avoid pacing the right ventricle. And that actually speaks to the rationale for doing this study to look at the difference in outcomes between BiV and RV pacing. There was a wide distribution of LV ejection fractions at randomization, and what you can see here is that there's a big spread anywhere from 15% on upwards of 50%. A few patients slipped in who exceeded their cutoff of 50%, but most were in the range of, say, 25 to 45% or so. This is the key slide from the trial showing the main outcome. And so remember, we had a composite endpoint of mortality, heart failure-related urgent care, or a significant increase in LV end systolic volume index. That primary endpoint was reduced by 27% in the BiV arm compared to the RV arm. This was highly significant with a posterior probability of 0.999, which is another way of saying highly statistically significant, and is the main outcome of the BLOCK-HF trial, showing that biventricular pacing results in better outcomes with these patients than RV pacing alone. We also looked at these results splitting out the CRTD and the CRTP patients, and even when you look at them separately, what you can see is that there is a significant relative risk reduction in the CRTP patients and the CRTD patients compared to those who are paced RV alone. The fact that there is a significant difference in ejection fraction or mean ejection fraction between these two groups shows that the results are not isolated to patients with the worst ejection fractions. When we had patients even with more preserved LV ejection fractions in the 40s, they had the same sorts of results and the same relative improvement in outcome compared to patients who had worse LV function. Also important is to note that it doesn't matter whether you look at men or women, baseline LV ejection fraction, New York Heart Association class, or AV block. All of the results across the board favor the BiV group compared to the RV group. So you can't tease out any particular degree of AV block or New York Heart Association class that favors RV pacing, certainly over BiV. It was all in favor of BiV pacing. Now we looked also at the primary endpoint. This was a sub-analysis that took out the LV end systolic volume index. And the reason we did that was we wanted to look at the clinical components of this endpoint separately to show that, to be sure that it wasn't all driven by the echo endpoint, and the answer is that it was not. So we saw the same relative change or the relative difference between BiV and RV pacing when looking at just the clinical endpoints as when we added in the LV end systolic volume index. Now this was a post hoc analysis, and so you cannot call it statistically significant, but the trend is exactly in the same direction when you have the whole composite endpoint together compared to the clinical endpoints alone. Now what we're looking at here are each component of the primary endpoint, and what you can see is that if you look at any component of the endpoint, the RV arm reached one of those endpoints 64% of the time versus 53% in the BiV arm. When you look at each of these components separately, in each case the RV arm more commonly or more often met the endpoint compared to the BiV arm. When we look at the rate of first heart failure hospitalization as well, there was a 30% relative risk reduction with BiV pacing compared to RV pacing. Now, we can't call that statistically significant because it wasn't pre-specified, but you can still see that the trend is in a favorable direction for BiV pacing. On the other hand, when we look at mortality, that by itself did not show a significant difference between the BiV and the RV arms. I want to switch now from the components of the primary endpoint to the clinical composite score and some of the more clinically based outcomes that are also very important for our patients. So I want to show first here what the definition of the clinical composite score is, just to remind everyone. And so what that is we ask a number of questions with respect to how the patient's doing. Did the patient die? Was the patient hospitalized for worsening heart failure? Was there a crossover due to worsening heart failure? Did the patient's New York Heart Association class get worse? Was there a moderately or markedly worse patient global assessment? If the answer to any of those questions is yes, then the patient is considered to be worsened by the clinical composite score. Then, if all of the answers to those questions are no, we move on to asking whether or not the New York Heart Association class improved, or whether there was a moderately or markedly improved patient global assessment. If the answer to either of those questions is yes, the patient is considered to have been improved. And then finally, if the answer to all of those questions is no, the patient is labeled unchanged. So now looking at that, if we look at the BiV pacing groups compared to RV pacing, what you can see is that BiV pacing is associated with better clinical composite scores than RV pacing at each time point here. So for example, if you look at 6 months, the number of patients who were improved with BiV pacing was 53% compared to 39% in the RV group. And on through the different 12, 18, and 24 months, the trend was the same throughout. So we have better clinical composite scores with biventricular pacing compared to RV pacing. We also looked at quality of life. And with that, we found that BiV pacing was associated with a greater improvement in quality of life compared to RV pacing. You can see the difference in the scores at 6 months, quite substantially in favor of BiV pacing, and then it persisted throughout the rest of the observation period. We also found that there were more BiV subjects than RV pacing subjects with a reduction in LV and systolic volume index at each time point. So remember, from the primary endpoint, we were looking at an increase in LV and systolic volume index, and that's the dark blue at the bottom, where you could see that that endpoint was reached more commonly with the RV pacing group. On the flip side of that, if you look at reduction in LV and systolic volume index, that more often occurred in the BiV arm compared to the RV arm. What this slide shows you now is a summary of secondary endpoints. First of all, we have the clinical outcomes, mortality, heart failure hospitalization. There's mortality and LV and systolic volume index, heart failure hospitalization, mortality, days hospitalized. We have cardiac function, volumes, ejection fraction, etc. We also have the clinical endpoints that I alluded to already. The composite score, quality of life, New York Heart Association class, and heart failure stage, and then finally arrhythmias. In every single one of these cases, the results either favored biventricular pacing or were neutral compared to RV pacing. There's not a single endpoint of any of these secondary endpoints where RV pacing was favored over biventricular pacing. I turn now to the safety endpoint, and first of all, the implant success rate was very high. It was close to 94%. The great majority of these patients had a successful implant of the device and lead system, including the LV lead. When we look at procedure-related complications, you can see that the number of complications was 17% overall. The events that occurred in the first 30 days was about 15%. And overall, there were LV lead-related complications in 6.3% of subjects with an implant attempt. So this is well within expected ranges that we have with CRT devices. If you look at the actual outcomes there, Cardiac failure, one could argue how much that's directly related to the implant procedure itself, but these were counted as events that we were looking at for safety. More importantly to me is that if you look at lead dislodgement, that's of course directly related to the implant itself. Phrenic nerve stimulation also is something that is directly related to the LV lead. So overall, I would say that in terms of safety endpoint, we certainly did quite well overall with the patients who got the CRT devices implanted. Looking at the strengths and limitations of the BLOCK-HF study, what we can say is that this was a very strong study design. It was a prospective, randomized, controlled, double-blind trial. And if you wonder how we could double-blind a trial where we're pacing patients RV versus BIV, what I want to point out is that the patients were double-blinded. They did not know which group they were randomized to. But in addition to that, the heart failure physician or the physician who was caring for the patient and assessing their heart failure status was blinded to the randomization group the patient was in. The electrophysiologist who was dealing with the device itself was not making the determinations about the patient's clinical status. This is the longest and largest study of this patient population. And in addition, we had consistency of the primary results by device group as well as by subgroup. We did have some limitations for the study. There was a long enrollment period because of the emergent nature in which patients present. Remember, when patients present to the emergency department and they have third-degree AV block, one can't wait days on end to determine whether or not you're going to go ahead and randomize them in a clinical trial. You have to move very quickly to get that patient a device. And so that presented its challenges in terms of getting patients enrolled and randomized, but fortunately, with persistence, we succeeded. I want to mention crossovers because there were crossovers in this study. The great majority of the crossovers that we had were from RV to biventricular pacing. It was about 25%. What I would point out, though, is that most of these patients met an endpoint before the crossover occurred. So it could have been the marked increase in LV and systolic volume index or heart failure would be the two ways that somebody could get crossed over. And I would also point out that when you have a crossover in a trial like this from RV to BIV pacing, and we found a benefit from BIV pacing, that actually dilutes the difference that you see between the two arms because we analyzed the RV group as if they always stayed in the RV group, even if some of them did cross over to biventricular pacing. Now you can see too there was a small percentage of patients who crossed over from BIV to RV pacing. Most of the time that was because of phrenic nerve stimulation. So with all of this, there is a new indication for Medtronic CRT-D and CRT-P for AV block. So these devices are now indicated in patients who have AV block, and I would note that it's specifically for patients in whom it is expected that there will be a high percentage of ventricular pacing that cannot be managed with algorithms to minimize RV pacing. In addition to the AV block, patients must have New York Heart Association class 1, 2, or 3 heart failure and an LV ejection fraction of 50% or less. And they must also be on optimal medical therapy. Now this slide summarizes the 2012 guidelines or American guidelines for CRT therapy, and some of this actually relates to standard CRT therapy that we have not been addressing today looking at the BLOCK-HF trial. So I want to just bring your attention to the bottom right-hand part of the screen where it talks about CRT can be useful for patients who have atrial fibrillation in whom they need ventricular pacing a high percentage of the time. And an example of that could be patients who have AV block from AV node ablation. And that is a current Class 2A recommendation. And these are patients in whom they were addressed with BLOCK-HF. And then on the bottom there it says CRT can be useful for patients who have an LV ejection fraction of 35% or less and who need a high percentage of pacing. In both cases, if you will note, these are lower ejection fractions and a higher group has not been addressed. And so here it summarizes this information from the guidelines in a slightly different way. And what you can see is that for patients who have AV block, permanent pacing is indicated. We know that, we've known that for years, and in most cases they're 1 or 2A indications. CRT therapy is indicated in patients who have AV block who have low ejection fractions by class 2A according to the guidelines. But I would point out that in that group of patients between 36 and 50% with LV ejection fraction, there's currently no recommendation. And so the problem is that so far we have had, as physicians, we've had to treat these patients and decide what kind of device to implant them with no study that gave us any indication as to whether or not an alternative to RV pacing would result in better outcomes. And now we have that information. So I would expect going forward that we will see revisions of the guidelines now that we have block HF because they specifically address this group of patients. So in conclusion, block HF demonstrated that BiV pacing is superior to traditional RV pacing for indicated patients with AV block and systolic dysfunction. We found a 27% relative risk reduction with biventricular pacing in the primary endpoint, and there was a 26% relative risk reduction when we looked at the primary endpoint, the clinical components of that without the LV and systolic volume index. The block HF primary endpoint results favored biventricular pacing across the board, CRTD and CRTP patients, all New York Heart Association classes that we studied, based on LV ejection fraction, and for all degrees of AV block. One question we have is were subgroups looked at, for example, how did patients with ejection fraction 45 to 50% benefit as compared to, with other groups? Well, we haven't teased it down to that level where we looked at that kind of a small subgroup. But remember, the CRTP patients had a mean ejection fraction of 43%, and that group had really right on target the same kind of benefit and outcomes with CRT therapy that we saw in the CRTD group, where the mean ejection fraction was 33%. So when you try to get down to that narrow range up in the 45 to 50, it's a relatively small number of patients, but yet overall we had about 400 patients in that CRTP group, and very many of them fell in that range. So we're very comfortable that in subgroups that we looked at, that there's benefit whether you have the higher end of the ejection fraction or lower. I will point out, though, that we did not include patients with ejection fractions over 50%, and so we can make no claims as to whether or not they also would have done better, and that's not included in the current indication. How do I know a patient needs a lot of pacing? Well, that's a clinical judgment. We do have algorithms currently that allow us to minimize right ventricular pacing in, for example, patients who have sinus node dysfunction, or in patients who have very intermittent AV block. If I see a patient where it's very transient AV block and then they're in sinus rhythm, they've got a reasonable PR interval, one of the things one can do is at the time of device implantation is pace the patient at 100 beats per minute as we did in block HF. And if there is consistent one-to-one conduction from the atrium to the ventricle, one could go ahead and decide to implant a standard dual chamber device and then use algorithms such as MVP to minimize the amount of ventricular pacing. If the patient currently has second-degree AV block or third-degree AV block, though, and it's pretty persistent, I don't think that patient will do well, and MVP actually isn't going to work because she'll flip over to dual chamber pacing all the time, and that's the kind of patient that I would want to implant a CRT device at the time that I implant the patient. If we wanted to look at why one would implant or whether it might make sense to implant a device and then see how the patient does, again, I think it's better to try to make this determination up front as to how much pacing you think a patient will need. Another factor I might throw in that I didn't mention before is what kind of medications does the patient need? So for example, if you're seeing some intermittent second-degree AV block now, and you know that you need to put the patient on beta blocker therapy to treat LV dysfunction, the only thing that's going to do is increase the amount of ventricular pacing that you get. And given that, that would push me more towards using the CRT device than trying to use MVP. So if a patient is going to need ventricular pacing, or you're going to have to treat them with medication, they've got established coronary disease or heart or LV dysfunction. Given those scenarios, that would push me towards doing the CRT device at the time. Why don't you want to upgrade? Well, one of the problems you see is that whenever you implant a device in a patient and you come back later on and then you want to open up that pocket again and do an upgrade, and it especially depends on how much time that you wait, there's the risk of infection with a reoperation that's always higher with the next procedure than it is with the index procedure. And then there's the problem that if you get very late on, access issues and ability to get that other lead in place. So the more one can make that decision at the time that you're implanting the initial device, I think the better off you are. Do I expect block HF to impact the guidelines? Actually, I do. And this has been a real unmet need for us as electrophysiologists. We have known that there's a group of patients who are indicated for CRT. Remember, most of the CRT patients, all of the studies that were done early on, were not in AV block patients. They were done in patients who had heart failure, who had mostly left bundle branch block, but wide QRS durations with intact AV conduction. This is a different group now. These are patients who have AV block, where we had a strong suspicion that patients would do worse if they had a chronic RV pacing. And we now have the data that show us that that is true. Given that we've demonstrated that biventricular pacing is superior to RV pacing in these patients, and particularly in this previously unstudied group with ejection fractions between 36 and 50%, I absolutely expect that guidelines must change to include this group of patients and provide an indication for pacing when the next revision comes out. Sometimes we get asked about the composite endpoint that we used. Well, one of the reasons we use a composite endpoint in any study has to do with the number of patients that you need to study in order to determine whether whether there is a significant difference between the two treatment groups. So composite endpoints help in that regard, in that by having several components to it, the number of patients that must be enrolled in the study is somewhat lower. So then the question becomes, what do you put into the composite endpoint? Well, certainly mortality and heart failure related urgent care are very important factors to look at in any patient in whom you're going to have a pacemaker or pacing done where you're concerned about outcomes. The LV end systolic volume index came about, again, to enrich the number of endpoints that we had, but also because we know that when LV end systolic volume index increases to a significant extent, that those are the patients who tend to have worse outcomes later on. And indeed, in block HF, what we frequently found was that once the patient met that echo endpoint, they then went on, not uncommonly, to have the heart failure hospitalization, or in some cases there were deaths related to that. So it is a very legitimate endpoint to indicate worsening heart function that we used in the study. What percentage of patients had left bundle branch block, and how did this affect the results? About a third of the patients overall had left bundle branch block at baseline. We haven't actually analyzed that separately at this point. I've actually had a question in my mind of how relevant that really is. I think one issue could be that if someone had marked left bundle branch block to start with, that we may possibly are taking a group that would be expected to benefit from CRT. But on the other hand, if these patients had marked AV block anyway, the minute that you put the pacemaker in, you've changed the situation. So it's not like a patient who had bundle branch block and intact AV conduction, where you could look at CRT versus no CRT. Whether these patients had left bundle or right bundle to start with or whatever, after the fact, they essentially have iatrogenic left bundle branch block because we're pacing the RV at that point. Will Medicare cover CRT for patients with AV block and systolic dysfunction? Currently, yes, that is true in most instances. We do know in the state of Florida that there's a specific regulation right now that they are not covering it. We are actually trying to get that changed because I think I would have every expectation that patients in Florida should benefit just as much as anybody else. But currently it is not covered down there. But in other instances, yes, we are finding that there is coverage for what is a very reasonable to me indication for pacing, for the way we should pace patients who have AV block. For block HF, the key points to take home are that we're looking at patients who have some degree of LV dysfunction, mild, moderate, or worse, who have AV block. They need to be paced in the ventricle chronically. And when that occurs, we have better outcomes when we do biventricular pacing compared to RV pacing. And with that, I'd like to thank you all for your attention this afternoon. I hope you enjoyed the program.